So there is a small change in the topic here. Instead of the holistic care of a patient, we have not touched on the pediatric uveitis. So Professor Quan will be touching on the pediatric uveitis, which I think again is very important.
So I think that, thank you. I thought that this way is more practical rather than the term holistic that Dr. Agro asked me. I seem a little bit mythical to me, so that's why we're going to go with this one. Okay, so when we talk about pediatric uveitis, that's a very important topic, really. It's covered a number of aspects in here. And it's the same principle that we want to do. In other words, we again, even more important for us to try to control the inflammation as much as possible, because you even have a longer life ahead of you for these children, and you don't want them to go and then by the time they get up, they have no more vision in their eye. That would be really worse. So the aspect is to make sure that you look at the case and you determine whether it's chronic, recurrent, or serious disease, that type of thing, and whether or not there's any potential complication that can look at this, and then the presentation with the various pathology that you could see. So those are some of the issues. And then for children, it's even very important that you try to preserve the vision and maintain it as fast as possible, because as you know, there's a concept of amblyopia. That's a problem that we also try to avoid for these children too. We don't want them to grow up and then by the time that you fix it, there's no vision left because of the fact that they grow up without that vision. So that landed a little bit level of difficulty going on. The various dilemma that we have in our children, patient with uveitis and children, is that the corticosteroid that we use, should we say, a little bit freely in adult, at least for the short time. With children, that is a concern because many of them, you don't want the growth retardation to occur, and therefore you want to make sure that that be addressed, and definitely even more important so than for children and adults. The issue of cataract and glaucoma and also linked together as well. Again, for cataract, it's hard because in adult, when you have cataract, you can remove them. It's usually not a big deal. In children, you remove them. Let's say you remove the cataract, then you have to watch out what type of lens you put it in because they're going to grow. So therefore, it's not going to be a good solution, and we try to avoid any type of cataract surgery in young children because of that aspect. And then when you look at the non-steroidal immunomodulation with that, you have a potential toxicity that we don't necessarily see in much in adult. Surgical risk as well too. When you enter the vitreous and you enter the retina in the children, you will gain so much respect because you have to be really, really careful when you operate on vitreoretinal surgery in children, because if you happen to make any break at all in the retina, the game is very over because of so much proliferation. They will develop proliferative vitreoretinopathy, PVR, and so on. So that makes it very complicated. So we have a lot of respect when we operate on children for this matter. Regarding how common, how problem this is actually a situation that we see quite often. It's very, for example, is less than an adult, but still 4.3 to 6. That's some of the epidemiology studies coming out. The prevalence is also less than an adult, but when they exist, it's so important. High incident and prevalent in developing world, that certainly is true. 5-10% in tertiary setting, so that's also true. So every 10 patients I see, one of them is in pediatric group, 5 or younger. That's important for that. What type of etiology should we say that we see that? When we talk about pediatric uveitis, the most common one, of course, is the juvenile idiopathic arthritis, JIA. So that's very much seen. On the other hand, we also see a posterior uveitis in the form of toxoplasmosis because of the transmission between mother and so on. So that's important that we notice that and pay attention to that as well. The at least the way I see is mainly posterior uveitis, but because that is a sort of like a preference pattern and also biases, they refer the harder case to tertiary center from here. So additional information here, you can see that was in the 1960s. Now, if you look at back in the 1996 to one more recent study about a decade ago, is that again you have toxoplasmosis, and then in the that also still a very popular aspect from there. From here, the referral bias when we put together data like this, it comes from our practice. And many times our practice in the university setting are very much refer the more difficult cases of getting this aspect, and so that's what we see. But in overall, among the pediatric cases, probably about 5% or so that are infectious, versus somewhere in the Middle East where it's about a third of the patient will be infectious from there. So let's spend the next part of the talk on the JA-associated neurocyclitis. This is, you heard already from Professor Gupta this morning, this is a condition that's quite with trouble. the eyes is very quiet. You don't see the red eye. That's the reason why the parent do not necessarily detect it, and it's only detected when the patient failed the vision test in school or something. That's what they do. But other than that, they don't have of that situation. So it's peak about onset about 6 months to 4 years of age. Not always that they have articular onset. And as we know, the more problem we see is when we have palsy articular when it's less than 5 joint involvement. Uveitis may precede the onset of arthritis, and that's very true because oftentimes that the eye finding then help to stimulate whether or not you will then work up to see the joint disease. And then the systemic and ocular inflammatory activity may be independent. This is a very much a true statement. So oftentimes the pediatric rheumatologist will send a note to us and say the patient is quiet, so do you want us to change anything? We will do, or we either change ourselves or we ask them to help if we see the eye finding is not proportionally the same. In other words, you can have a joint that's very quiet, but it's the eye that's caused the problem. So please be very careful with that. And again, you need to speak up. In other words, if the eyes is active, we cannot just let them be maintained or whatever dose of medication for the joint. We have to speed up the process to hide with that. What are some of the features that predispose to significant uveitis in the children? So oligoarticular disease, that's definitely true. So palsy articular, less than 5 joint, that's important. The younger age of onset, that's important too. The younger it is, the more dangerous. The female sex, so that is also making it a worse prognosis. And the fourth one is AA positive. So the worst case would be a young girl, like 3 years old girl, that have 2 joint problem. And with uveitis, those are aggressive as you can be, because you definitely don't want them. You will see the course is much more difficult than when they have more joint involvement, for example. The predictor of poor visual prognosis. So these are some of the aspects that we have seen. Severity of disease at presentation, the male sex in some study there, the short interval from the onset of arthritis to uveitis. In other words, they're more aggressive. They present with both arthritis and uveitis in the same period. And then the HLA-DR5, these are some of the academic questions that we have seen being shown in the literature, that if you have this locus, the disease is a little bit more aggressive. The long-term prognosis, on the other hand, is guarded if you were to see significant visual impairment. So if not properly maintained, you can have blindness in a bit of number of 10% of the patient or so. So it's very important. And blindness here can be due to not only the uveitis itself, but also to the secondary effect. For example, they cause damage to the ciliary body with chronic inflammation, and the eye become first you have high pressure, and then you have low pressure problem with that aspect from here. So let's start with this case here. This is the case that I learned during fellowship as well. So this is a 10-year-old woman, a girl, who has 4-year history of bilateral uveitis, has been treated with topical steroid as well as also regional steroid injection because this aspect. The patient has developed glaucoma in both eyes, had PRP in both eyes, has already, because of glaucoma, has had an armored valve placed in the left eye, and then after the surgery, that the girl developed cataract formation in the left eye, and so poorly controlled many flare. At the time of presentation to us, the patient was on prednisone acetate, on cyclosporin eye drops, on cyclogel for dilation and pressure drop. So here is the thing. The visual key was 20/50 in the right eye and hand motion in the left eye. Pressure, you can see 26 OD, 19 OS, some vitreous cell, and this is what it looked like here. Okay, so this is the situation of the case here of this patient. You already see the part of the armament exposed onto the cornea, also going through that. You also see the cataract formation here, and this is the eye that present to us. So what would you like to do this time? So is this an eye that we can consider, we can rehabilitate it, or we say that this is an end stage eye? I'm sorry? You can do something. What would you like to do? And what do we do with the pressure elevation? So the armored valve was put there, so you don't want to do so. So I think your point is that obviously it's protruding right now, so we have to reposition this, correct? We have to reposition that if we still think that, but do you want to proceed if we know, what about the overall prognosis? Is this an eye that's salvageable? So let's go back, right? So pressure is right now is hand motion. Pressure is 19 that I, we don't know yet. Some vitreous cell in this aspect. So what should we do in here? So this is sometimes what you decide in this aspect, because sometimes people will just say this is an eye that probably not salvageable at this moment. But the thing that keeps us going with this moment is that at least the eye pressure is of a reasonable range. If this eye were to come in with a pressure of like say 2 or 3, that is certainly much more concerning and we'd be concerned. So here the B scan, because we could not see anything, was quite unremarkable. The UVM shows this open angle, so this aspect from there. So how the patient came to the service? The mother has been, she was a nurse, and so she's been reading a thing, and she was saying to the referring physician, can the patient be treated with something beyond the systemic corticosteroid? And so the idea, the outside was that was too dangerous. You don't want to poison your child very much in this aspect from here. And that the pediatric ophthalmologist, however, did indicate that we should revise, just like with many, the tube revision, because otherwise you can get endophthalmitis since open. But then the glaucoma specialist in this case feel that we shouldn't do very much with this because it's too risky, and this eye has very much no hope with this, so don't go too far to advance with this aspect. So with all of that to the mixture thinking, because the eye, you can see, it was not in a good shape, was in this aspect. But again, the decision for us to thought about it, look at all this comment, and decide to move forward, because we thought that given the pressure and the thing, and that the back of the eye was not really of a problem of any detachment and thing, we decided to proceed it. But here was some of the question that was the debate. How would you address it? You leave it as is because the eye is considered somewhat quiet. Should we extract the cataract? Should we extract the cataract and also revise the valve? Or should we just continue with the steroid therapy because it has kept the eye quiet? Or do we begin other treatment with IMT with this situation here? So those are some of the common questions that we asked the patient, and obviously the mother also want to know, the parent want to know what to do in this case here. So what we have decided that given the fact that the valve was already protruding to like that, so that's quite dangerous. We don't want to make, because right now the B scan showed that the posterior segment was still intact. That means there's no detachment, there's no evidence of endophthalmitis, the vitreous was clear. So we thought that leaving behind further would be a problem. And so we operate immediately that we preserve the valve, but then we put it out from the cornea to the glass you have heard already to use. So we use that to cover part of the corneal defect. We remove the cataract in this case, and we know in this type of thing, when we do cataract in this situation, when you do pediatric cataract surgery, the best way to do is that we actually remove the entire lens plus the capsule as well too, because I say when you're a child, it's really difficult for you to try to put the correct lens in because it also grows. So remove the whole thing, and the best way to do that is when you do vitrectomy, and you also do as much as you can of very much of the membrane that is attached to that. If you want to pull, remove that. And then you reinstall the tube again. So we reposition the tube in this case for this aspect. And then you left the eye aphakic, because we would discuss in the near future, what do we do with this type of thing? Should we put in the lens, should we not put in the lens? But given the status of the eye, we thought that it's safer not to put the lens in at that time with here. So this is the course in the left eye, which is operating here. The eye is comfortable. The visual acuity is counting finger, this aspect from there, and we continue to very strong, but at the same time, we stop methotrexate in this patient from there. And then subsequently following through this aspect, the IC was remain comfortable. The patient, as you can see, continue on the methotrexate and the pressure drop, and the pressure is borderline in this aspect from there. Now, the problem now go to the right eye. The right eye now have 3 plus vitreous cell in this aspect from there. So what should we do in this case? Right, the patient is currently on methotrexate, and the patient do have some cell now in this aspect, and it's not unusual that you see cell just spill into the vitreous, for example, from the AC that go in there. And so would you increase the treatment from a drug, or you do vitrectomy? Increase. Okay, let's see, you increase the thing. So how much do you increase? So we talk about, Dr. Rubesh was just talking about the dose of methotrexate. Interestingly enough, you can use the dose of methotrexate higher in children than in adult. So that's the tricky part of this thing. So in adult, I told you I only go up to about 25 or so milligrams weekly. At most I can go. In children, you need to go a little bit higher. Or the other option is that, what if we want better penetration? What do we do with methotrexate? So, no, you don't do intravitreal because it's a little bit hard to do it in children, but what you can change that, instead of oral methotrexate, you change to intramuscular. So that you actually get a little higher dose. So methotrexate can be delivered as an oral or intramuscular. So sometimes to get a better concentration, what you do is you go with the higher dose methotrexate in here. But in this case, given the fact that it's cell, given the fact that we decided at that time to go ahead and treat the patient and do a vitrectomy in this patient in here. So then afterward, we continue to maintain that because with some of this uveitis, initially we can control with the vitrectomy part for that. So that's what the course of a patient that is usually presented to us. In addition, they have a very difficult situation here. This is bilateral disease. You have to look at multiple aspects to get the vision as best as you could before they develop amblyopia. And of course, there's a social factor as well too, because many of these children, understandably so, have very concerned parents. So you want to make sure that they're also in agreement with you as well, and you want to make sure that is moving along. So the approach that we do to this is that anytime you see inflammation, you want to eliminate that. If you think there's any potential infection, let's try to control that. And then you basically use a little steroid you can for this aspect. And then for these children, you can implement steroid-sparing agent. Like I said, if you want to go to higher dose of that, you should and you can much higher dose than adult. The same approach that we take is a step-ladder algorithm, whereby you use from the medication with the least risk to that with a little bit higher risk in this aspect. So you use topical steroid and use in the short term. You need periocular steroid if you need to consider that. And again, for children, obviously you do it under anesthesia. And then some that non-steroidal agent that we use, naproxen is the one I commonly use myself in this day. And then you still a very brief course. I emphasize again, this is a brief course of steroid therapy because you don't want to suppress the growth of the child in this aspect. And then you start IMT as soon as you can. Anytime you need to consider both a diagnostic and therapeutic post-retinal vitrectomy if it needs to be here. What are some of the IMT agents that we use? So methotrexate here, as you can see, I said we go up higher. So you can go up higher, 30 milligrams weekly, and that should probably work with that. Although I do not go beyond 25, but for children you can go to 30 in this aspect. You also see azathioprine here, mycophenolate, cyclosporin, chloramphocyl. I use with much caution with this, and cyclophosphamide only when the thing is really active and melting away. So the cyclophosphamide, if you need to give to them and you have control, then of course you give it by post intravenous cyclophosphamide. Why wouldn't we consider oral cyclophosphamide? What's the difference between intravenous and oral cyclophosphamide? Which one have more side effect? Oral. So oral, because you use it under chronic long term, the side effect is much higher, profile is much higher. So I use it to stop whatever process I need to do, and I use it very quickly for that. But long term use, I have much respect for oral cyclophosphamide because the side effect profile is pretty high from this aspect. IVIG in certain these conditions, yes. Infliximab, definitely from there, you've heard we've been talking about over the last few days here in this aspect. So now, I'm sharing with you some of the data from Boston that have looked at the visual outcome in prognosticators in JIA-associated uveitis here. So for this aspect, from this here, so we've tried to ask the question, what are some of the indications, what are some of the signs that when you have some JIA come into your clinic, how well or how not so well they will proceed in the future. So one of that would be that how soon that the patient get presented to the uveitis specialist, and also what type of visual acuity they have. So initially, if they have a poor visual acuity, the outcome is usually very poor in this. So from this series that came out from Boston, they have 65 subjects with JE-associated uveitis, 43 with greater than 6-month follow-up, and they look at the number of parameters and also look at what had happened to the various approach to treatment. And so the parameters that have significantly correlated with a good vision acuity, for example, what are the things that give you the chance of saying, okay, this child will move forward and do quite well. So the vision at presentation, that's helpful. If you have good vision in the beginning, you usually tend to have good vision. The use of systemic medication and not steroid. In other words, those who have been treated very well with the IMT, and not just on systemic side, tend to do better. The older age of disease onset, since we say the younger they are, the more risky it becomes. So the older onset usually give you a better prognosis. Male usually do better than female, and then absent glaucoma. So these are some of the parameters that correlate with good vision in this aspect here. And they also, then they move on to this group, and they look at some of the cataract surgery patients that appear in this aspect that I've shown from here. So for that, the probability of improvement seems to be reasonable in this group, that we can intervene sooner for that aspect from there. Now, let's come up with this aspect about lens implantation in these children. So this is the issue that has been in debate for many decades now, and it's not an easy solution. In other words, when you remove a lens from a child, do you or do you not put back the intraocular lens in there, an artificial lens? And in which situation? So when the patient has pediatric uveitis, that makes it very complicated, because we have to look at significant number of factors before we decide. Because at times you will see, for example, there will be a case where you will have the lens is, the pupil then distort and the lens is shifted. Then, or cases like this, where the lens now misplaced or displaced it over there, and then we also have the large deposit in this aspect. Very much a chronic low-grade intraocular inflammation for a while. So that's why there's a debate, there's a question of whether or not should we or should we not put in the primary intraocular lens in the group of pediatric uveitis. Have any of you have come across this situation in your practice yet? In other words, if you have to remove a lens in the child, do you or do you not put the intraocular lens in? Anyone have handled any pediatric cases? No. Okay, you consider yourself fortunate yet, because eventually in your career you will come across of this, but it's not an easy question. It's very hard in this, and so we have to look at this. Some evidence in the literature say that that there is a very good reasonable to do, and so this series from about 18 patients with JA here, they have all have acrylic PCRL in there. They have aggressive therapy for uveitis, and so at the end of those 18 patients, 99, they seem to have very good outcome with that, and they didn't find any difference between whether the patient had JA or other disease beforehand. So some conclusion right now, we feel that the intraocular lens implantation is not always contraindicated in those with pediatric uveitis, including uveitis with JA. In other words, we feel that in some cases you can put it in, but it has to be very carefully controlled so that you make sure that you don't have inflammation. Corinne Lauder from the Cleveland Clinic has also come up with a similar kind of conclusion like we did in Boston in this part. In other words, if you, in her case, you look at adult patient who had JA uveitis many years before cataract surgery, and she did the aspect and she put in an IOL, and Corinne noticed that it's reasonably good outcome if she did that, so there's no problem with that. On the other hand, Gary Holland from UCLA, one of the major uveitis leaders from UCLA, and he and his team from there have indicated that the young JA patient, you should not put the lens in because there's complication. And because of the fact that they put it in, they cause a disaster, the chronic inflammation, chronic in there, the pressure started to go down, so eventually the lens have to remove. So they recommend there's absolutely no placement of the lens inside. And that has been the debate on this from there. So at this moment, when I consider this type of cases of this nature, I do consider the potential of putting the lens in only if I have seen such a beautiful quiescence of the eye in the child. If the child have a different type of recurrences, I mean in adult, we say that we do not operate on any patient with uveitis unless the uveitis has been stable for about 90 days or so, because otherwise the cataract surgery would be very unsuccessful. In children, I believe that's even longer than that period of time. We're under time pressure, but at the same time, we don't want to operate the eye that's not working well. So in cases where the eye has been quiet and has shown very much no synesthesia and no problem, I think that would be a good reasonable to consider, but not overall. Because what you don't want is you want something like this left over behind, you leave it in, and then so after that, the people are synesthesia down, and then you do this nature. So that's not very good. So the series from Boston, when I was there, looking at the outcome of JA without implant versus with implant. And so you can see sometimes you can get a good recently outcome without the implant, and you do like contact lens correction afterward. And then when you look at the series that the outcome that with the implant, it seemed to be also reasonably well as well too, with a lot of the vision improved afterwards. So you have seen the benefit of getting the lens in there. And of course, if you can quiet the patient enough before your cataract surgery, then of course that's better to have the lens in, because then you don't have so much to worry about the amblyopia of this aspect. But again, when I say that the lens there is usually the little bit all the times when you can a little bit more confidence about what type of lens you put inside from there. Because otherwise you don't want a situation like this, and we have seen this all the time, in which case we have to try to remove the lens out from there. So thus far, based on the various debate, again, the question still remain of whether or not you should or you should not put it in. But I would say that in here I put well-select cases and with adequate control of the perioperative inflammation need to be installed before you consider this. So if you're gonna do this, you need to put a lot of time to really control the eye very, very well, and then you peri off the patient very much, whether you increase the dose of steroid, you give intraoperative metronidazole to control, and then in the post-op, you be very, very careful with the aspect. The thing is that during the surgery, it may look great, it may look fine, you put in the IOL, look out, but then if you don't control as well in the post-operative period, that's when trouble become with that from there. The techniques is that you clearly need, on those type of patient with pediatric uveitis, you clearly need IMT in the pre-op period and post-op period to try to help out for you. So now let's look at some of the final slide here. Looking back at what we have learned so far, for patients with pediatric uveitis, early referral, this morning I talked about referral, and for children it's even more important that you should refer the patient to a ocular immunologist experienced with using IMT to children, because they, even more than adults, need this type of information control in order for them to have good prognosis. So that definitely is true. Second, the care is even greater because now there are different people involved. So you look at the ophthalmologist, you look at the pediatrician to help out with this, and the rheumatologist experienced in managing this type of thing, so pediatric rheumatologist, and that definitely is so important there. And then finally, the early and aggressive introduction of the steroid-sparing agent, I think that's also very important in order for us to control this aspect from there. So the model of care with children with JA and other form of pediatrics uveitis will be the early referral that I just mentioned, and also partnering with others. So this more than ever shown is important like that. And I think with that together, we can probably be able to make a difference from here with that regard. And so thank you for your attention for this aspect here. Great, thank you. So let's take some questions here from here.
Hi.
Yeah.
I wanted to go back to the case where you had the patient, the fellow eye was subsequently affected. There was spillover cells in the vitreous, and instead of stepping up the systemic immunosuppression, we went on to a vitrectomy for that patient.
Yes. So the question is, why would I do that to this aspect from here? We have seen how the response of the left eye has behaved. In other words, the patient has been on treatment before and still with medical therapy did not go there, not go up. So when the right eye occurred, we use what we have learned in the left eye, and we say, okay, in this particular case, the left eye has performed really well. So we approach using a similar approach.
Is it similar to what
Doctor, yes.
Yeah, doctor. That's
Yes, so this morning, Professor Gupta mentioned that he doesn't use as much of the cry anymore, and nowadays, if they don't respond so well to IMT, he moves forward quickly to the surgery.
Yep.
And that's what that aspect from there.
Is it this whole thing about, if you have the vitreous over there, and then you've got a little bursa, then you sequester all the inflammatory.
Yes, and so that's what you do, but again, you don't want always to use as a first line, always thinking, because again, if you ever do surgery, vitreoretinal surgery in children, you see how important it is to be meticulous, because anything that you potentially touch the lens or you gout the lens, that lead to a lot of complication aspect from there. And so that's the reason why we do it, but it's not our first line therapy. In this case, given the history of what the patient has had, that's the reason why we decide to do it that.
Thanks.
Different question?
I think we should thank Professor Quan actually, who's come all the way from US and just to kind of, so he's been really helping us with all those doubts. Yeah, you have some questions, please.
Good afternoon, doctor. I would just like to ask your, we have a patient that is a 19-year-old male. He's diagnosed with JIA since he was 10 years old. And then he was lost to follow up at around after 9 years with dislocated lens, subluxated lens, both eyes, and about plus 2 to 3 cells. One eye, we did lens extraction with IOL implant, and then the other eye with cataract. We already referred this patient to an immunologist, maintained with methotrexate. However, the cells doesn't seem to resolve with topical steroids, oral steroids, and methotrexate. I know that we should have a low threshold for explantation of the IOL, but do you suggest that we wait for the inflammation to subside before we explant the IOL again, or explant even with inflamed?
So I want to clarify. So this case, the patient is pseudophakic in both eyes, but the
Pseudophakic
lens
in one eye,
and
and then the other eye has subluxated cataract.
okay, so the eye that have subluxated cataract, and that eye is the eye also that have the cell, or both eye have cell.
Both eyes.
Both eye have cell.
still
And
have
what is the pressure in each
intense
eye? Do you
inflammation.
have the patient?
Borderline to about 20, but we're already giving timolol.
And do you have the opportunity to look at, for example, the UVM to see whether there's any member, anything involved in that aspect? So in other words, is the angle, the ciliary body somewhat healthy?
We don't have UVM available.
Okay. So here's the situation where both eye have chronic inflammation in this
Yes.
aspect from there. The eye that have the sublux lens clearly will need surgery soon anyway, so you have to get that lens out. It's a natural lens, the sublux, right?
Yes.
Okay, so that need to be out. The other one, the IOL, is in there, but is it in good position?
Yes, because we did
You did that change. Okay, so I would say that given the fact that the patient have the subluxation of lens inflammation, I would speed up the improvement to control the inflammation quickly. And in this case, I will actually pose the patient with steroids so that he gives a lot of this with the goal to get the eye quite enough for you to go and to remove the lens, the natural lens in there. And given the fact that the patient has inflammation like that, and since the patient is 19, that means that he's old enough perhaps to wear contact lens temporarily in there. I would probably not necessarily put in the lens yet in that aspect. But right now, your question is whether or not you can operate on this patient. And I say that given the fact that the lens is sublux, it probably would be good that you do that surgery soon. And the way to control it is that you really pose the patient with corticosteroid to control the inflammation so that you can go in.
But we don't have to wait until it's zero cells.
No, but that's what I'm saying.
Yes.
So you don't want to operate right now, but that's why you give the patient like steroid, like acutely for high dose steroid, and then so after a week or so, the inflammation should settle, especially if you give them oral prednisone at a high dose to control that, and then you pose the patient, and then you do the surgery.
Okay, thank you, doctor.
Okay, to do that, I think there.
Thank you.
Thank you, Professor. I just want to ask a question. In Singapore, we are blessed enough that we actually don't have that many GIA patients with uveitis. I'm very interested with the issue of GIA patient cataract surgery needing IOL or not. I'm just wondering because those older publications at that stage, they heavily have biologics. I'm just wondering, with the recent years, when more people using biologics and the inflammation is a lot more well controlled, this group, I don't have the experience here. I only have one child that is under my care, not really GIA, but that child actually settled very well with biologics and with Remicade. I'm just wondering, with Remicade and Humira, all these biologics around, would that make people more prone to give put IOL in because the inflammation more well controlled? I'm just wondering, whether is that a trend coming along?
Yes, so thank you for that point, and then I agree with you. So that's why my opinion, looking all of this and the time if I make decision right now, if the patient is very quiet and you point out with a number of biologic, whether it's infliximab or adalimumab with all this TNF alpha inhibition, that I can be beautifully controlled and quiet. So I believe that if that's the case, we get the case, we have seen the patient, I'm somewhat even conservative. So instead of the 3 months type of thing, I actually want to see at least a 6 months or longer when they're completely quiet. And then I do it, and then I put an IOL in the aspect, but then I keep them on very high IMT level also with steroid around the post-op period. But you're correct, that is, I do not believe that we should automatically not put in the lens in all these cases. If they have been controlled so well, I think that we should give them a chance to do it. So I would put in the lens, like you say, if we have all these patients already in biologic and they're very well controlled. So,
No, regarding this, cataract surgery and putting
Yes.
an implant, if I see an eye where the pressure is low, where they have peripheral anti-synechiae, and then they have a lot of posterior synechiae. So the extent of synechiae, the peripheral anti-synechiae and the low pressure would indicate to me that this eye has had long-standing inflammation which remained uncontrolled for a long time. I'll be wary of putting an implant in this kind of eye. But if it's an early case where the eye didn't have a chance to develop posterior synechiae or peripheral anti-synechiae and the pressure is good, you bring it under control with using, the biological therapy, keep it under control, put an implant, no issues. But the case which was told by her, where there is a subluxury lens, and they have, I don't know how did they fix the implant in that eye? Okay, did they use some kind of a Sione ring or scleral fixated? Now what you are doing is already an eye which has been inflamed, and now you put a haptics of the lens sutured to the uveal tissue. Okay, I think it's adding insult to the injury. So this eye, the implant will have to go whether you like it or not. Okay, and that is where when you said UBM, the UBM is very critical to see if haptic of this implant, the surgeons are very happy putting the implant. They don't know where this haptic is going. Because what happens is, these eyes are prone to a lot of fibrosis. There is a capsular fibrosis, and we have seen the haptics being thrown out of the bag. The surgeon put it in the bag, but over a period of time, over several months and years, the haptic is pushed out of the bag, and now it goes and sits against the ciliary body, inflaming or inciting inflammation. So when you are combining and you are doing a phacosurgery in children with this inflammatory disease, what we suggest is that it must be combined. One is a large capsular access. Second is do a posterior primary capsulotomy surgical and do anterior vitrectomy. Okay, remove all the vitreous scaffold so that the fibrous scar tissue doesn't have a chance to form behind the implant. And these children, they really don't have the kind of what we call the lens epithelial cell proliferation, the L-shaped pearls. They don't get that kind of PCO which adults get. They get is that these lens epithelial cells, they undergo fibrous metaplasia. So they become fibrous macrophages or fibrous fibrocytes, and they lead to a lot of fibrous scar tissue. So this surgeon, our cataract surgeon, has been very happy, putting an implant, because he doesn't see this patient later.
correct.
Okay, so when we see these patients, we feel very unhappy.
Yes, yes, and so I fully agree. That's some very beautiful point that Professor Gupta just mentioned to you. So number one, the pressure tell you a lot. If the eye has low pressure to begin with, that's a bad sign to do that. And I would not put in a lens in because that just creates more of a problem later when it does that. And second, you really, if you can do that, you need to figure out where exactly you're going to put it. And so the UVM will be very excellent to do so. And that's what I meant. Like a lot of the time, the cataract surgeon, they put it in the, or if you do it during your surgery, at the end of the case, everything looks so great, the people around thing, but then unfortunately within a week, you begin to see synechiae, and that's a bad sign to begin to see that, and then it's just go downhill from there. So when in doubt, again, if the patient like 19 or some 18 before, when in doubt, you should just not put the lens in because contact lens correction is just easily done with this, and but to prevent other problems. Otherwise, we just end up with the eye that you see there.
Just on the topic of lens, how many of you will put a multifocal IOL, another one? Hopefully that's the consensus, at least. People are not putting it. We have seen, and I have seen in my practice also, people have put all kind of multifocal, and these are some of those who are the top cataract surgeons, high volume cataract surgeon, and it just, I think any kind of uveitis for that matter, right, Professor Gupta? Any kind of uveitis, not only this year.
For multifocal IOLs, no eye disease.
No eye disease.
No eye disease. Whether you have
That's a
glaucoma,
fully.
you have diabetic retinopathy, you have dry eye, you have any surgery. Don't put these expensive.
Ask them to donate whatever the $5,000 go to a fund that we can do research whether, because that's how much it costs in the US to run multifocals, like I think 25 or 3,000 a lens. And so instead of wasting that money, they eventually have to be removed. Then they should just support our research fund.
We do see that. We have seen people coming with the artificial color iris. There was someone started those colored iris they put in, and then the pressure is 50, 60, and hyphema and all kind of stuff. I think the same thing with the multifocal. No, strict no. That's something another again strong message which you can take. At least this crowd should not put any of those things. And maybe if you can convince some of your high volume phacosurgeons also not to do that. They may be great, but not this size, definitely not.
That's one more question. What is the role of checking rheumatoid factor in patients with JIA, and does it carry any prognostication?
So rheumatoid factor is, I mentioned to you, I don't check it for adult, doesn't help. But Professor Gupta mentioned today, so that considered the seropositive or seronegative, and in a child is usually help you to give a prognosis. So seropositive is usually put you a little bit more at risk, again with the positive ANA as well. So that's why you check it. It's more for prognostic factor and not necessarily for diagnostic. And it's only helpful in that group, very young group thing. In adult, I don't find them to be helpful at all.
Okay.
Yeah.
Okay, time for the last tea break for this year, for this ISASO, and then we'll gather back for a rapid fire breakout session. So I've got some cases where if you want to group up, but we'll try to do rapid fire. Not the cases are not that difficult like yesterday, but something for you to just give you a bolus dose of IVMP kind of stuff, and then so that you can just go through those kind of cases very quickly. But we'll see how it goes, and we'll not probably go into the detail of this.